Hi everyone, good afternoon. Thank you for joining this afternoon's HCQY. Statin therapy, easy as 1, 2, 3, and ASCVD. We'll be starting in just a couple minutes, so hang on tight. Good afternoon. Thank you for joining. Before we get started, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer speaker system by default. If you would prefer to join over the phone, please select phone call in the audio pane, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Thank you for joining, and we're going to just give it a couple more minutes for everyone to join the call.
So good afternoon, everyone. Thank you for joining. Health Choice Network's Healthcare Quality Institute for American Heart Month. And we are honored to have a presentation on statin therapy as easy as 1, 2, 3, and the atherosclerotic cardiovascular disease. Today's session is going to be by our colleague, Dr. Kate Curley, the Director of Chronic Disease Prevention at the American Medical Association. So Dr. Curley, welcome, and please proceed with your presentation. We are honored to have you here today.
Thanks so much, Dr. Long. Really appreciate that introduction. And I have to point out that I think you said the title wrong because it didn't rhyme. It should be statin therapy, easy as 1, 2, 3, and ASCVD. Although I'm not sure if my presentation is going to convince everyone that it's as easy as 1, 2, 3, but hopefully you'll feel that way by the end. By way of further introduction, I'm a family physician and a former, well, still current health services researcher, and I work full-time at the American Medical Association. I work at the AMA really because of our mission, which is promoting the art and science of medicine and the betterment of public health. And I'm fortunate enough to work in our Improving Health Outcomes unit here at the AMA, which is really about delivering on the latter piece of that mission, that betterment of public health. And my unit here, Improving Health Outcomes, really began our focused work about 6 years ago when the AMA decided to stop spreading ourselves so thin and trying to address really sort of every health issue under the sun, but focus more deeply on a couple of issues where we felt we could move the needle better. And we decided to focus our work on the prevention of cardiovascular disease, primarily by improving blood pressure control around the nation, and then also working on preventing type 2 diabetes, because these, as you all know, are some of the most common, costliest conditions associated with the most morbidity and mortality for our patient populations. And so we do our work through a variety of different ways, including partnering with our advocacy team around health policy. I lead a lot of work regarding medical education in chronic disease prevention and management. But really the heart of our work is delivering quality improvement programs directly with healthcare organizations. So we have a quality improvement program called the MAP-BP program that we deliver to healthcare organizations to improve blood pressure control. We have an initiative called AMA Prevent Diabetes. We work with healthcare organizations on identifying, planning, and executing diabetes prevention strategies. And then we've been expanding our work to include lipid management, statin therapy as well. And one of the first ways we're doing that is through this partnership, which is how I'm talking with you all today, a partnership between CDC's Million Hearts Project, NAC, the National Association of Community Health Centers, and AMA are all collaborating together on a project that many of the centers on the line right now are participating in, and it has multiple arms, but one of the arms of that project is to improve quality of care around statin management. And that project really focuses on improving statin use or increasing statin use among the 3 highest risk groups of people who benefit from statins. So we'll talk a lot about that today, as well as other aspects of statin management. And so with that, why don't I launch in? I have a lot that I want to cover over the next 90 minutes, although it's not going to take 90 minutes. We'll have plenty of time for questions and answers at the end. But what I'll talk about is first outlining the highlights from the 2018 ACC and AHA guideline on the management of blood cholesterol. We'll talk and really demonstrate the function or how the 10-year ASCVD risk calculator works and what it means for our patients. We'll talk about the 4 key statin management groups, and those include the 3 high-risk groups that are the focus of the NAC and CDC Million Hearts endeavor, but we will also talk about the primary prevention patient group. We'll talk about issues that challenge us all related to statin-associated side effects and statin adherence and ways we can address those issues. And at the end, I'll wrap up with some hopefully straightforward QI strategies, quality improvement strategies, designed to improve the quality of care for our patients who fall into these statin management groups that we'll talk a lot about today. So now just to jump into the guideline, I think it's helpful to kind of discuss in the beginning here that a lot of the cardiovascular disease related recommendations and guidelines have been shifting over the past decade from sort of this old paradigm where we used to, identify that someone had a cholesterol abnormality, or identify that a patient had a blood pressure elevation, or identify that they have diabetes, and then sort of treating each of those numbers or each of those conditions kind of separately. And we're really trying to move towards this new paradigm where we're looking at our patients as a whole. We're assessing their overall ASCVD cardiovascular risk, so their risk for atherosclerotic cardiovascular disease and cerebrovascular disease. We're looking at that whole risk picture, and then we're identifying places where we can reduce the patient's risk by using things like statins or blood pressure medication or diabetes medication or intensive lifestyle therapy, among other things. So we're trying to kind of all move towards this mindset where it is less about identifying numbers, treating numbers, identifying conditions in isolation, and more about how can we manage our patient's overall risk picture. And I think that's really reflected in the approach, kind of the high-level approach of the ACC/AHA 2018 cholesterol guideline. So I've tried to sort of depict that overall approach here with a, I hope, straightforward diagram. And it really boils down to sort of 5 steps. The first step for each of our patients is to assess their risk and determine whether they fall into a statin management group. And so we assess their risk really by looking at their discrete risk factors and the conditions that they have. And then in some cases, we also assess their risk by calculating a 10-year ASCVD risk score. We'll talk a lot more about that in a few minutes. And then by assessing their risk, we determine whether or not they fall into one of these 4 statin management groups that I'll talk about on the next slide. So once we know if a patient falls into that statin management group, we then want to do 2 things with them simultaneously. So we want to make sure that everybody gets plugged into lifestyle therapies. Unfortunately, I don't really have lifestyle therapies covered in great deal in this talk, although it's one of my favorite topics. So if you all want, I can address some questions about that at the end. But lifestyle therapy is really the foundation for all of our patients who fall into a statin management group. It's extremely important, but it's also not enough because we know that dietary interventions, physical activity interventions, typically result in a reduction of LDL that's kind of in the single digits in terms of milligram per deciliter reduction, so 5 to 10 milligrams per deciliter. And so while it's impactful on LDL, it's definitely impactful on risk reduction overall. It doesn't, lifestyle alone tends to not generate the drop in LDL that we want to see to be reassured that we're significantly reducing our patient's risk. And we can reduce that risk more if we utilize statins as well. And so the guideline really has gotten away from this idea of try lifestyle therapy first, and then if it's not successful, then go to a statin. And really the recommendations now have shifted towards you want to initiate both lifestyle therapy as well as a statin at the same time to maximize risk reduction. So once you get your patient on their appropriate intensity statin, and we'll talk a lot about what those are, you're then going to want to monitor their response. And then if they're not responding adequately after you've addressed medication adherence issues, then there are certain groups of people where you may consider a non-statin medication. And this is really reserved for high-risk groups. Again, I'm not going to talk about this piece as much in this talk. I have it in a couple of places. We'll mention it a little bit. So that's our sort of overall approach. Determine risk, utilize lifestyle therapy and statin therapy, monitor the response, and then for a few people, consider additional therapy. So what are the 4 statin management groups that I've already mentioned a couple of times? So our highest risk group are people who have clinical ASCVD. And so this would include people who have a history of MI, myocardial infarction, or acute coronary syndromes, people who have stable or unstable angina, people with a history of stroke or TIA, as well as people with peripheral arterial disease. So people with any of those conditions fall into that clinical ASCVD group, and they are our highest risk group that we think about. The second group are adults between the ages of 20 and 75 who have a very elevated LDL-C. So these are people who have an LDL level of greater than or equal to 190 milligrams per deciliter. And more or less, people who have an LDL of this level typically are displaying a phenotype associated with familial hypercholesterolemia. So most of these folks have a genetic abnormality that is driving up their LDL and substantially increasing their risk of developing ASCVD down the road. So they fall into a special high-risk category. They're less common than our other groups, but you will find folks out there who have a very elevated LDL, frequently at a younger age, and they are kind of that second high-risk group that we're focused on here. The third high-risk group are people who have diabetes, but who don't fall into one of the categories above. So these are people who do not have clinical ASCVD, they do not have a very elevated LDL above 190. Instead, they have an LDL between 70 and 189, but they also have diabetes. They are also a high-risk group, and they fall into their own statin management group. And then our fourth group are the people who have none of the above, so no ASCVD, no very elevated LDL, no diabetes, but they have elevated risk for other reasons, and this is the group where we will actually utilize that 10-year ASCVD risk calculation to determine whether or not these individuals need statins. So for those first three groups, the ASCVD group, the LDL group, and the diabetes group, you do not need to calculate a 10-year ASCVD risk in order to determine whether or not those patients need statins. You skip that step. You determine that they're in that group just based off of the characteristics listed here, and you will manage their statins accordingly. So before I talk about what the recommendations are in terms of statin intensities for each of those groups, I want to present a really short depiction of sort of the overall benefits and risks of statins in our high-risk groups. So the way to look at this table, this is actually from a study that is modeling NHANES data. So NHANES, big national survey tracking health risk factors and health outcomes across a lot of people. And in this study, they took a sample of people from NHANES, and they used them to do some estimations at the higher population level around the US. And so the way you read this table is, let's take that ASCVD row right there going across. In this study, they looked at people in NHANES. These people represented about 5,730,000 people in the US. And they said, they basically tested the idea that if we were to give all of these people who have clinical ASCVD an appropriate intensity statin, what we would then expect to see is we would expect to see 62,600 fewer ASCVD events per year. So that's the number of events prevented per year if we use appropriate intensity statins. And what that translates to is that we would have a 10-year number needed to treat of 9, which means that if we gave 9 people statins for 10 years, we would prevent one ASCVD risk or one ASCVD event. If you're not super familiar with numbers needed to treat, the lower the better. A 10-year number needed to treat of 9 to prevent one incident is actually really, really great. And so this tells us that people with ASCVD stand to benefit significantly from taking a statin. Same thing holds for all of the groups below. The LDL group, the number needed to treat over 10 years is 19. For most of our diabetes patients that fall into that third row there, the number needed to treat is 15. So this speaks really strongly to the benefits of statins in these higher risk groups. And then below the table there, I have numbers needed to harm. So the numbers needed to harm are 5-year numbers needed to harm. And what they mean are that we would need to treat 167 people with a moderate intensity statin for 5 years before we would see one serious adverse event. Similarly, we'd need to treat 63 people with a high-intensity statin for 5 years before we would see one serious adverse event. And so if you look at the trade-offs between benefits and harms, for all of these high-risk groups, the benefits at a population level substantially outweigh the potential harms. One thing that's really true of statins, from now tens of thousands of people who have taken them over multiple decades across 30-some randomized controlled trials, one kind of truth that has been observed at this point is that the higher a person's ASCVD risk is at baseline, the more they stand to benefit from a statin. Meanwhile, the risk of side effects from statins isn't really tied to a person's baseline risk. It's probably more tied to dose. And overall, the risk is really, really low. So that benefit-risk trade-off just becomes, more heavily weighted towards the benefit piece as a person's risk for ASCVD increases. Okay, so let's start talking about sort of actually using statins in patients in our 4 statin management groups. First, I just want to lay out the different intensities of statin therapy. The guideline talks a lot about using high-intensity statin therapy or using moderate-intensity statin therapy for most of these statin management groups. For high intensity, that means a statin that is dosed so that it will typically lower LDL by 50% or more. We really have 2 options on the market in the US for that. So we have atorvastatin dosed 40 to 80 milligrams per day and rosuvastatin dosed at 20 to 40 milligrams per day. And then for moderate intensity statins, these are statins that will lower LDL by 30 to 49%. So we have a lot of options here on the market in the US. You can see all the options listed there on the slide. I want to point out that the asterisk indicates statins that have a longer half-life. And what that means is that we can actually dose them any time of the day. So traditionally, we tell patients to take statins at bedtime, but for these longer half-life statins, you can actually have patients take them any time of the day, which can make it a lot easier for some people, especially if for any given reason they take most of their medications in the morning. There's no reason why they can't take their atorvastatin or their rosuvastatin in the morning as well. So just keep that in mind. You have some options with those longer half-life statins there. Okay, we've made it to our first poll question. So Bill is a 38-year-old man who establishes care with you, and he has hypertension, and he also had an MI. He had a myocardial infarction 2 years ago. He's on aspirin, and he's on hypertension meds only. His LDL is 130, and you calculate his 10-year ASCVD risk, and it's 2.0%. So off the top of your heads, how would you all approach lipid therapy for Bill? Would you not give him a statin? Would you give him a low-intensity statin, moderate-intensity statin, or a high-intensity statin? And I'm just going to sit here quietly for a moment while folks respond.
Okay, so we're going to go ahead and launch this poll question, which will just keep the actual piece on the bottom. So how would you approach the lipid therapy for Bill? We're about 57% respondents have answered the poll question. So we'll just give it one more second. Great, so we close the poll, and these are our results, Dr. Curley.
Let's see, if I open this, will I be able to see them?
Yep. 8% is the highest respondent to low intensity statin.
Got it. Okay, so
And
low
then following 1% is moderate and high.
Okay, so let's move forward and we'll see what the correct answer is here, I think on the next slide actually. All right, so let's talk about that first statin management group, the folks with clinical ASCVD. And Bill, despite his young age and his 10-year ASCVD risk that I quoted there being just 2%, I'll back up to that slide. Despite his age, his LDL, his ASCVD risk, he had an MI, so he had a myocardial infarction. So he falls into the group of people who actually have clinical ASCVD, despite the rest of his picture not actually making a ton of sense there. And I also want to point out that the 10-year ASCVD risk calculator actually isn't really applicable to him. So it's intended for people who have not had an ASCVD event. So his risk calculation, if you just plug in all of his variables, actually doesn't really represent his true risk, which is clear because of his history of having an actual myocardial infarction. So he falls into the group of people who have clinical ASCVD. And this is a relatively straightforward group. If people are under the age of 75, the recommendation is really clear with extremely high quality evidence, grade A recommendation that folks should be taking a high intensity statin. And that's because they stand to benefit significantly and the risks are very minimal. One nice thing about the guideline, the newer guideline from 2018, is that it does more to address people who are over the age of 75. Older guidelines kind of left us hanging about what should we do with these folks. But the guideline says that for people over the age of 75, they recommend a moderate to high intensity statin after considering a number of factors, including their overall sort of risk picture, potential for adverse events or drug-drug interactions. I have a slide about interactions later, so we'll talk about that a bit. Frailty, as well as patient preferences. And I think a reasonable rule of thumb is, if you have a patient who has a reasonable life expectancy still, typically 3 years or more, most of those folks, you're going to want to follow similar guidelines to the younger age group. So if someone has a pretty substantial life expectancy, and we all have plenty of patients in their late 70s who you could easily see them living for 10 more years or longer, even if they already had an MI. And those are folks who are really likely to benefit from a statin. I would consider a higher intensity statin in them. On the other hand, if you have a patient with significant frailty or really limited life expectancy, that's when you're going to consider, perhaps a moderate dose statin for those folks. And then another new piece of the 2018 guideline is that it actually talks about patients with heart failure. So if you have a patient who has heart failure due to ischemic CVD, but still has a life expectancy of 3 years or more, they recommend that you consider using a moderate intensity statin for those people. So really the takeaway from this piece for our patients who have clinical ASCVD, the vast majority of them, a high intensity statin is going to be the appropriate treatment for them. So now shifting over to our next statin management group. These are the folks with an LDL of 190 or higher. And again, this can be a younger age group. These are folks who have that phenotype consistent with familial hypercholesterolemia, or what's sometimes called pure hypercholesterolemia. So for these folks, as long as they fall between the age of 20 to 75, the recommendation is to use a high intensity statin. And in the case where they can't tolerate that, at least a maximally tolerated statin. But generally across the board for these people, a high intensity statin is what is recommended. This is one group of people where you do really want to be tracking their LDL reduction. And if they're not achieving that 50% LDL, or their LDL is still greater than 100, these are folks where adding additional medications may be reasonable. So first addition would typically be ezetimibe, and if they are still not reaching their goal of a 50% LDL reduction and keeping their LDL below 100, then after the statin and the ezetimibe, you might add a PCSK9 inhibitor. These are expensive, difficult to prescribe, and it's not a situation that we encounter very often, but that is one type of patient that you may see occasionally where the PCSK9 inhibitor might actually come into play. But the main takeaway for this group with a very elevated LDL is that you want to be getting them on a high-intensity statin. And then getting into our third statin management group. So this is the group of people who have diabetes. Their LDL falls between 70 and 189, and they don't have clinical ASCVD. So across the board for our adults between ages 40 and 75, if they have diabetes, they should be at a minimum on a moderate intensity statin. And this is a little bit of a change from previous guidelines. You don't actually have to calculate somebody's 10-year ASCVD risk. If they have diabetes, across the board, at a minimum, you're starting a moderate intensity statin. Now, for people who have multiple ASCVD risk factors, we'll talk about risk factors a little more in a moment, a high-intensity statin may actually be a better choice for them. For people over the age of 75, if they're already taking a statin, many of our patients are already on a statin when they hit the age of 75, it's definitely reasonable to continue that statin. And if you have a patient who is newly diagnosed with diabetes, past the age of 75, it's still reasonable to consider starting a statin after a risk-benefit discussion. And I would put forth kind of similar guidelines to what I said about patients with ASCVD. If you have that, 76, 77-year-old who still has a really significant life expectancy ahead of them, that is someone who is likely to benefit from being on a statin. And generally, you want to use a statin dose that would be recommended for a patient falling between the ages of 40 and 75, so typically a moderate dose statin for that person. The guideline does also newly address people who fall between the ages of 20 and 39 with diabetes, so those younger adults that unfortunately we're all seeing more and more of. For those people, you want to continue or consider using a statin if they have had a long duration of their diabetes. So if they've had diabetes for 10 years or more, you really want to start managing them like the group that falls between the ages of 40 and 75. Or if they already have evidence of microvascular disease. So if they already have albuminuria, that is a reason to initiate a statin on this patient, even though they're under the age of 40. So across the board for diabetes, moderate intensity statin for the most part, but for people who have those additional ASCVD risk factors, you want to think about a high intensity statin. Okay, so we just talked about our three sort of highest risk statin groups. And as I've said, I think a few times now, for all of those folks, you do not need to calculate a 10-year ASCVD risk to determine whether or not they should be taking a statin. But now I want to shift towards that primary prevention group, that last group. And this is where that 10-year ASCVD risk calculator really comes into play. So before I show you how the calculator works a little bit, I just want to give you the classifications that you use to determine somebody's risk. So if somebody has a 10-year ASCVD risk calculation that is less than 5%, they fall into the low risk category. If somebody's 10-year ASCVD risk is between 5 and just under 7.5%, they fall into the borderline risk group. If their ASCVD risk is 7.5% to just under 20%, they fall into the intermediate risk group. And then if their 10-year ASCVD risk is 20% or higher, they are in that high risk group. A lot of the statin recommendation really focuses for the most part on people falling into that intermediate risk group or people falling into that high risk group. So I suspect many of you are very familiar with the 10-year ASCVD risk calculator. You can access it on the American College of Cardiology website. There's a lot of places where you can track down that calculator. Lots of folks may have it already built into their EHR. If you don't, it will probably be there soon. And I do have a link near the end of the presentation to get you to that calculator in case you don't have an easy way of accessing it already. But what I want to show you here on this slide is sort of how the risk calculator functions if we play with some of the variables in the calculator. So the main variables that contribute to calculating an ASCVD risk are gender, age, race, total cholesterol and HDL, blood pressure, and then whether or not the patient is treated for hypertension, whether or not they have diabetes, and whether or not they are a smoker. And what I'm doing on this slide and the next few slides is I'm keeping patient 1 the same. Patient 1 is sort of our reference patient. He is a man who is 45 years old, he's Caucasian, total cholesterol is 220, HDL is 45, his blood pressure is 130/80. He doesn't have a hypertension diagnosis, he does not have diabetes, and he is not a smoker, or rather he is not treated for hypertension. And if we were to go right now, plug all those variables into the calculator, it would tell us that his 10-year risk of having an ASCVD event is 2.8%. Now, if we just change one thing about this person, we keep all of his stats the same, but now he is a 65-year-old man, his 10-year ASCVD risk increases to 14.8%. So age is actually the most influential variable in the risk calculator. So next, if we keep patient 1 the same, again, he's this 45-year-old man with all those factors I discussed before, and instead we make him a woman. So we just toggle that gender variable. What we see is a bit of a decline in risk. So now this person's 10-year ASCVD risk is 1.4%. Now, I will say that how gender plays a role in this equation fluctuates a lot depending on age. So it's a little bit less influential at this age, and then later on, being a woman, you're going to see some higher risk as well. So next, if we toggle race, so if we just make this individual an African American, you can see how the 10-year risk increases. It is now at 4.5% compared to 2.8%. So race is pretty influential in this calculator. We'll talk more about that in a moment. And then last piece, very influential variable, is whether or not the person is a smoker. So if we make this person a smoker, their risk goes from 2.8% to 7.4%. So putting in a plug that smoking cessation is really important in overall ASCVD risk reduction as well. That's just a couple examples of how the risk calculator works. There are some limitations of the risk calculator. So it can overestimate risk a little bit, especially at the lower end of the spectrum. We'll talk about a little bit about how to deal with folks at the low end of the spectrum when you're not sure what to do with them. The calculator was developed using data from Caucasians and African Americans. So it works best in those individuals. So it can overestimate risk for people of East Asian descent and people of Mexican descent. And it can underestimate risk for Native Americans, South Asians, and Puerto Ricans. And you've also probably noticed that all of the variables or all of the risk factors that we know of that contribute to ASCVD risk aren't included in the risk calculator. So for example, family history is not included in the risk calculator. And that's because when they were developing this calculator, they had to use the data that were available to them. And some of these variables don't have either good quality or structured data to work with. And so that's why the guideline is built to sort of account for that and gives us some guidance on how to deal with that. And we'll talk about that in just a second here. Okay, so let's talk about what the guideline says in terms of primary prevention for people who don't have, these are people who don't have clinical ASCVD already, they don't have an extremely elevated LDL, and they don't have diabetes. So they fall between the ages of 40 and 75, and they have an LDL between 70 and 189. In this case, that is when you want to do your 10-year ASCVD risk calculation, and you're going to use that result to determine how to treat that patient. So for the intermediate risk group, those are the people who have that 10-year ASCVD risk between 7.5 and just under 20%. For those folks, it is recommended that they use a moderate intensity statin, and that's a grade A recommendation. So it's a high quality recommendation. For the high risk group, the people who have a very elevated 10-year ASCVD risk of 20% or higher, you're essentially using a high-intensity statin. You want a statin that will lower LDL by 50% or more. And then they get into some of the wishy-washy stuff. I won't call it wishy-washy, but the pieces where it's time to use your clinical judgment. So if you have somebody who has intermediate risk, so that 7.5 to 20% range, but they also have risk-enhancing factors, you want to initiate or intensify that statin. So even consider a high-intensity statin. And on my next slide, I will show you examples of risk-enhancing factors. If someone is borderline risk, so that was that group that we don't talk about that much, but it's the group that falls between 5 and 7.5% on their 10-year ASCVD calculator. Those folks, if they have risk-enhancing factors, you may want to sort of bump them up a group and consider a moderate intensity statin for them. And then in these sort of intermediate and borderline risk cases, where the statin decision is just tough, you're having a hard time deciding with your patient, or you think their risk calculation just doesn't quite describe their risk picture very accurately, that is when you consider using a coronary artery calcium score. So we'll talk about both risk-enhancing factors and the CAC a little bit more right here. So risk-enhancing factors include having a family history of premature ASCVD, having an LDL that is below 190, but higher than 160, so kind of the higher end of that moderate range there. People who have metabolic syndrome, people with chronic kidney disease, people with chronic inflammatory conditions like rheumatoid arthritis or Crohn's, women who have a history of premature menopause or preeclampsia, with preeclampsia being a really significant risk factor for eventual development of ASCVD, as well as people who fall into higher risk races or ethnicities. And one of the reasons that we have these sort of risk-enhancing factors here to think about is that, as I said, the risk calculator really doesn't take these things into account. So when we're trying to really stand back and look at the overall ASCVD risk picture for our patients, we want to do the risk calculation, but we also want to look at these other factors as well. And if your patient has, sort of a borderline or intermediate risk calculation, but they also have these risk-enhancing factors, especially if they have multiple risk-enhancing factors, those are people that you ideally want to treat more aggressively with statins because the risk calculation isn't really representing their full risk picture. So those are common risk-enhancing factors. And now let's talk about the CAC for a second, the coronary artery calcium score. 2018 guideline is really the first time that they are recommending some use of this. It used to be less available or very expensive. The sort of guideline writers are feeling like it's now affordable enough and widely available enough to incorporate into the guideline, as well as we have a large enough body of evidence to start to understand how we should use this. And it is not something that should be ordered in a blanket fashion across all of our patients. It really should just be used to sort of reclassify risk for patients where statin benefit is questionable. And so that could be somebody who, let's say you calculate their risk to be right around 7.5%, but you're looking at them and you're thinking, you look really healthy. It doesn't seem like your risk is that high. For those folks where the risk picture just doesn't quite add up to you, or they are very on the fence about wanting to take a statin, they really don't like the idea, the coronary artery calcium score can help you make a clearer decision. And the way you use it is if the individual has a score of 0, that basically gets them a get out of jail free card. So if they have a score of 0, that means that their 10-year ASCVD risk is actually extremely low, and you and your patient can feel good about foregoing a statin for the time being. If the score is anything higher than 0, then you sort of need to go with the risk calculation. The other, this patient likely has some risk that you maybe aren't seeing, visually in front of you, but you generally want to proceed with the statin recommendation in that case. There are some people where you should not use a CAC. So don't get a coronary artery calcium score for somebody who is already on a statin. It is not helpful to you. It really is not meaningful for someone who is already on a statin. Same thing with somebody who is a smoker. People who have diabetes, a CAC is really not appropriate. People with that strong family history of ASCVD, as well as people with chronic inflammatory conditions. So several of these are sort of these risk-enhancing factors, or these just factors that really strongly drive cardiovascular disease risk. And so a CAC doesn't outweigh those risk factors. Okay, last bit about primary prevention. We're nearing the end of the guideline summary, and we'll talk about some other interesting things. But the last piece to share about primary prevention for people who are age 75 or older, a moderate intensity statin there is typically appropriate. For people who have, and these are people who fall into that intermediate risk group or elevated risk group. For people who are greater than or older than 75 but have limited functional status or limited life expectancy, that is one situation where it's reasonable to forego a statin. For younger adults, the guideline points out for patients between the ages of 20 and 39, they do not make a recommendation to use statins for primary prevention. We still don't really have great evidence that statins are useful purely for primary prevention in this age group. And the guideline, interestingly, actually comments on teenagers. It comments on pediatric patients between the ages of 10 and 19 who have essentially that familial hypercholesterolemia phenotype. They have the very elevated LDL greater than 190, or they have that moderately elevated LDL with that family history of early ASCVD. For those kids, statins might be reasonable if you don't see improvement in their LDL with lifestyle therapy. So that really rounds out our primary prevention group. It's probably the most complicated group, and that is where that 10-year ASCVD risk calculation comes into play. So one last kind of drier note before we switch to some, I think, slightly more interesting stuff. A note about interactions. So this table shows you medications that you may encounter, several of them actually being cardiovascular-related medications, and tries to give you a quick snapshot of when you need to think about interactions or not. The way you read this table is most of the statins here are blue. Any statin that's listed as blue is a statin where you can consider using it, recognizing that you may actually be increasing the patient's exposure to statins, potentially, theoretically, increasing their risk of side effects. For the most part, people will do just fine. But if you have a choice of a different statin, you may want to go with that. The red ones, which really is just under the cyclosporin, tacrolimus, and gemfibrozil rows, those red statins are ones where you actually do want to avoid that interaction. And then the green ones on the warfarin row there are actually situations where there is an interaction. So there is definitely an interaction between warfarin and all of those statins, but you still want to use those statins because of their risk reduction potential. You just need to, manage that INR in your patient. All right, we're coming up here on our next poll question as we shift topics a little bit. So Bill he was our patient who had that MI, and we decided to initiate, and he agreed to initiate a high intensity statin. So he started taking atorvastatin 40 milligrams daily. You have him come back for a follow-up lipid panel 6 weeks later, and his LDL-C has decreased by about 25%. And as a reminder, with high intensity statins, we want to see a decrease of at least 50%. So what would you do next? Would you increase his atorvastatin to 80 milligrams daily? Would you assess his adherence to his atorvastatin? Or would you switch him to rosuvastatin 20 milligrams daily? And while I can't see it on my screen, you all should be seeing a poll question.
Yeah, we have the poll launched. So everyone should see that on their screen, the 3 different options to vote on. So we're about 25% responses in so far. So we'll give it just a couple more minutes for people to go ahead and answer the poll. Okay, so we have some comments in the chat to repeat the question. So Bill, your patient with a history of an MI, initiates atorvastatin, 40 milligrams daily. On a follow-up panel 6 weeks later, his LDL-C has decreased by about 25%. What would you do next? We're going to go ahead then and close the poll and share the results. So 67% of the respondents chose assess Bill's adherence to his statin.
Yes, I love that answer. Perfect. All right, so let's talk about follow-up monitoring. And by the way, because my computer is doing something odd, are you all still seeing me on the video?
Yes.
And is it projecting it onto everyone's screen as well?
Yep, we're on the follow-up monitoring after initiating statins. Perfect. And the bullet points.
All right, I think my technology is functioning. Okay, so let's talk about follow-up as a way to transition into talking about medication adherence. So once you start somebody on a statin, you want to do a follow-up lipid panel anywhere from 4 to 12 weeks later. And the main purpose of that lipid panel is to check for medication adherence. And from then on, you can follow a lipid panel for most patients annually after that. One of the nice things about statins is that they cause LDL reductions that are really predictable. So if you give your patient a high-intensity statin and they're taking it for the most part as prescribed, you should see a 50% reduction in their LDL, if not a little bit greater. Same thing with a moderate intensity statin. If they're taking it generally as prescribed, you should see a drop in their LDL that falls somewhere between 30 and 50%. So if you are not seeing a reduction in LDL that you're expecting, that really should trigger a conversation about medication adherence. I also want to point out that you don't need to monitor transaminases. So you don't need to do routine liver function tests in your patients taking statins. You don't even need to check baseline liver function tests. We'll talk more in a second about how the rate of actual liver injury is extremely, extremely low in patients with statins. The only folks where you may want to monitor transaminases, or you should monitor transaminases are people who have chronic stable liver disease. They're sort of the remaining group where you do want to keep an eye on their LFTs. But otherwise, across the board, people do not need follow-up LFTs, but they do need that follow-up lipid panel really to look for adherence. All right. So, non-adherence, it is a huge, huge issue across all of medicine, not just with thinking about cholesterol management. So 20 to 30% of all prescriptions are never filled by our patients, and 50% of the meds that we prescribe for chronic diseases are not taken as we prescribe them. And this causes a lot of issues in our country. So it's medication non-adherence is estimated to be responsible for about 125,000 deaths every year, as well as causing about 10% of hospitalizations that we all deal with. And so when you think about the fact that many of our patients who need statins are not actually receiving them, they're not prescribed them on our side, but then those who are prescribed them, many of them may also not be taking them as prescribed. We have a major gap in care that we need to address, both by improving our prescribing rates and using shared decision-making with our patients, but also addressing medication adherence. And unfortunately, medication adherence is a really tricky subject, and there aren't silver bullets to solving it, but there are some things that we can do in our practices to address this. There are a lot of kind of conceptual models and frameworks out there to describe why medication non-adherence happens. This is one really straightforward one presented by the World Health Organization back in 2003. In this case, they break down reasons for non-adherence into social and economic factors, patient-related factors, therapy-related factors, condition-related factors, and health system factors. I think if you read that list, a lot of this stuff will sound very, very familiar to you all. Statins have some tricky issues just related to the nature of the drug itself. We all feel the effects of the healthcare system challenges. We're all extremely busy. We all have 50 million priorities to deal with every day. It's really hard to find the time to have good conversations with our patients about medication adherence. So there are lots of factors at play. There are also some statin-specific reasons that patients may not adhere to their medication. Statin-associated muscle symptoms are extremely common. We'll talk about those more in a moment, as well as other statin-associated side effects. Statins are also really guilty for causing the nocebo response, which I think is kind of an interesting phenomenon. So if you think about it, hyperlipidemia really doesn't cause symptoms. And statins, while the benefits are really clear in studies, the benefits of statins are typically not felt by any individual patient. You don't feel better when you take a statin, but you may feel side effects from it. And compound this with the fact that the statin benefits, not only do you not feel them, but they're sort of abstract, they're very long term. What this all adds up to is that patients are a lot more likely to feel bad from taking their statins than they are to feel better from taking their statins. So rather than this sort of placebo response where people feel better from taking nothing, the nocebo response is where people actually feel worse despite the fact that they are taking something that has significant benefit for them. So that is a difficult situation for all of us to contend with. There are other issues, like I mentioned before. Sometimes folks struggle to adhere to the dosing regimen where they're supposed to take something at bedtime and it just doesn't fit into the rest of their medication schedule. There are things we can do about that. And then I think one of the biggest issues that we all are contending with is that there is a ton of misinformation or confusing information out in the world about statins. Everyone has heard about statins from their friends, from their family members, or they have heard some story recently on Good Morning America about how statins cause who knows what. And so there's tons of information out in the world that all of our patients are trying to sort through, and it's really, really challenging for them. And that actually is a place where I think we can play a really important role. So, strategies to addressing non-adherence, and this certainly applies to statins, and a lot of it applies to other medications as well. Step one is really just to look for the non-adherence, assess for whether non-adherence is happening. And you can do this through a number of different methods. There are screeners and questionnaires out there. Some of them are really brief, and I've seen lots of practices find creative ways to implement those in their workflows. You can use pill counts. If you have access to medication fill data, that can certainly give you some insights into whether your patient is filling their medicines or not. You can use other kind of contextual flags. So is this patient missing a lot of appointments? Are they not requesting refills, according to the schedule that you would expect? And all of these things are really useful techniques to assess non-adherence, but none of it's a substitute for really good, open, non-judgmental conversations with our patients. There's a lot of resources out there about sort of how to have sort of these non-judgmental conversations, language that you can use. Sometimes it's easier to back into it by just asking about side effects and going from there. And it's important to also acknowledge some of the just logistical challenges, the cost challenges that people may have with filling their medications. So step one is really assessing for the non-adherence. And then, like I said before, remember that you can also use your lipid panel as a means of assessing for non-adherence. You should see a predictable reduction in LDL according to whatever dose of statin your patient is on. And if you're not seeing that, that really should trigger that conversation and further assessment about non-adherence. And then once you start to identify non-adherence and potential reasons for it, which are many and varied, our next step is really to try to offer solutions to our patients. And like I said, there's no silver bullet for this. Solutions are going to vary patient by patient depending on what challenges they are encountering, but there are, a number of things that we can do. One is just to start with really good shared decision making at the beginning so that everyone has a clear understanding of what's expected and what may happen and how to handle it. Address statin-associated muscle symptoms. I'm going to talk a lot more about that in just a moment. You can use statins that have longer half-lives so that you can dose them with patients' other meds, making the medication regimen a little bit easier. I know this is, a duh comment to all of you, but prescribe low-cost generics wherever possible. There are some approaches that can help address that forgetfulness aspect, whether it's, reminders, timers, using blister packs that many pharmacies will prepare for patients. And then really frequent contact with the healthcare team has definitely been shown to help address non-adherence as well. And that doesn't need to be the doctor. Many members of the healthcare team can really contribute to addressing non-adherence. I do want to point out one note that all non-adherence is not due to forgetting. I know I'm really guilty of this. I've seen lots of other doctors be guilty of kind of jumping to conclusions that the reason our patients aren't adhering is because they're just forgetting to take their meds. Oh, if they just had a reminder, they would take their meds. But actually, intentional non-adherence is extremely common, and it is frequently very rational due to side effects, due to logistical issues. And so you need to have we all need to remember to keep an open mind. There could be a lot of factors playing into non-adherence, and things like reminders will not solve all of our non-adherence issues. But if we can do a good job here with supporting our patients, if we can connect, get to the bottom of their issues and start to offer solutions, it really is actually a great way to improve our relationships with our patients. And let's talk about statin-associated side effects, because I think this is just one of the most difficult things that we all deal with, both when we're initiating statins with our patients, as well as an issue that contributes to non-adherence. So our last polling question is just an open-ended question. I'd love to hear from you all about what some of the most common concerns, particularly in the side effect realm. What are the concerns that you hear from your patients about statins?
Right, perfect. Thank you, Dr. Curley. So we sent a chat message that includes a link to a Microsoft Forms where you can also input your response to the poll question. So we're going to go ahead and switch screens, and then we can have that showing as well. If you'd like to respond via the chat, that we will also read those answers as well.
And I think I can see a few things here. I think it's seeing muscular symptoms, perception that it will damage liver, concerns about memory loss, myalgias, joint pains. I think those are really common things that we've all heard. Anything else in the chat box that I'm missing?
So we do have a response in the chat box from Marty Folsom, and she's stating that they really don't want to take one more pill. Speaks to the issues of they don't feel better if they take the medication.
Yep. All of those things, I think, are things we hear really, really commonly. And hopefully folks will be able to view the next slide. But I have sort of a laundry list here of sort of common statin-associated side effects that in some cases our patients really truly do experience. In other cases, they're items that people have heard about. There's been news stories about them. Their aunt had these issues. So there's sort of a long list of side effects that we sort of all have to contend with and we potentially need to address with our patients when we're thinking about initiating statins. So some examples, common examples that we hear about include muscle problems, new onset diabetes, liver issues, dementia or memory problems, cataracts, cancer have come up all in the news at various points. And so quickly, I'm just going to kind of walk through what the sort of real risk is for all of these things. So statin-associated muscle symptoms, by the way, we're all supposed to be now using this acronym SAM just to describe statin-associated muscle symptoms. So when you look at the piles of randomized controlled trials, tens of thousands of patients, decades of research, the actual rate of serious statin-induced muscle injury is less than 0.1% of patients. So really quite rare. But if you look at observational studies and what people report sort of more in a real life setting, about 5 to 20% of patients complain of statin-associated muscle symptoms. I do want to point out, even though tendonitis isn't technically a muscle thing exactly, there have been no associations with tendonitis or joint issues as well in the literature, but muscle symptoms are pretty common, and it can range from, pain to weakness to sort of other vague symptoms. So, recommendations for how to handle statin-associated muscle symptoms. So first of all, a really important step, ideally, before you even initiate statins on your patients, is to actually assess and document their aches and pains in an objective way before you even start that statin, so that you do have sort of a baseline to go back to compare to later on. And then if your patient comes in complaining of muscle symptoms, I think one of the most helpful things out there to sort through all of this is the American College of Cardiology's statin intolerance tool. So it's freely available. There's an app for it. It is also on the website where you can access the risk calculator. And it's a cool tool that you can actually use alongside your patient to better characterize what their symptoms are and to start to figure out whether those symptoms are likely to be statin-induced or not. And then the tool actually gives you some suggestions about what to do next, depending on the individual situation that your patient is experiencing. And we'll talk about what to do next in just a moment. I want to talk about a couple other side effects first, though. Type 2 diabetes. So new onset diabetes appears to be a real issue that can be associated with statins. So the rate of new onset diabetes is estimated to be about 0.2% of people per year will develop type 2 diabetes associated with their statin use. So what should you do here? So first of all, it's definitely reasonable to assess and document for type 2 diabetes risk factors before you start your statin. But the guidelines really favors that the net benefits of statins strongly outweigh the risks, even in the case where someone actually develops new onset diabetes. So the guideline really pushes towards continuing that statin or using that statin, even in the case with new onset diabetes developing. People who have pre-existing risk factors for type 2 diabetes are those that are more likely to actually develop it, and you would manage them, as you would manage any other person with type 2 diabetes. But again, the guideline really pushes to still use that statin despite the risk of new onset diabetes, and really emphasizing healthy lifestyles for all of our patients in this case. Liver problems, as I kind of covered earlier, serious hepatotoxicity is extremely rare, less or around 0.001% of patients. So we have tons of data about this now, which is why the guidelines have really stepped back from saying that you need to be checking LFTs routinely in your patients. The kind of exception to that are those with chronic stable liver disease. Dementia, several studies out there about that, multiple meta-analyses. There appears to be no increased risk for dementia with statins, as well as no cognitive function, sort of memory problems, no decline there observed as well. If anything, there's a couple studies maybe suggesting that it might improve cognitive function, but really kind of the whole picture of evidence is that statins really don't do anything from a dementia or cognitive function standpoint. The management there is really about just having a good conversation with your patient about the evidence. Cataracts, no convincing evidence there. Again, dealing with that is just about talking with your patient about the risk. So it has been studied. There's no convincing evidence that statins cause cataracts. Same thing for cancer. So it's something that's absolutely been tracked for years. There is no convincing evidence that statins can cause cancers. So if you have a patient that does have a statin-associated side effect, again, with those muscle symptoms being the most common thing that people might experience, here are the steps to addressing those things. So really it starts from the very beginning with having a shared decision-making conversation with your patient prior to initiating statins, understanding what their own goals and values are, being really clear about what to expect. So we definitely recommend that you don't lead with the negative news. There have been some interesting studies out there showing that if you open your conversation with, well, I'm sure you've heard about a lot of the bad things that statins can do, that conversation probably is not going to result in that person taking a statin. On the other hand, if you open your conversation with, statins have a lot of benefits and you are a person who is likely to benefit significantly from taking a statin, that really sets a different tone for your conversation. So don't lead with the side effects, but do address the side effects. And it's really important to convey that these side effects can typically be addressed and they can almost always be resolved. So none of these issues are going to be long-term, irreversible issues. And you really just want to create an open space for your patients, encourage them to report symptoms if they have them. It's much better, we all wish our patients would just tell us when they get symptoms rather than just stopping the medication altogether and we don't have any idea. So encourage them to report symptoms, reassure them that if they develop symptoms, you will be able to deal with them with your patient. Next step, if they report symptoms, is to assess those symptoms well. Nothing is a substitute for a good history physical there, and your statin intolerance tool at the ACC's website can really actually help with that assessment at a pretty granular level. Ultimately, if you determine that the side effects are likely to be statin associated, your next step is to switch to a different statin, ideally at the same intensity. So we really prioritize trying to keep our high intensity people on a high intensity statin, albeit a different one, and our moderate intensity statin people on moderate intensity. So ideally switch statins, keep the intensity the same before you start backing down on the dose. I know costs and some other factors can sometimes limit your ability to switch statins, but ideally that's your first step. And then if the symptoms still persist, then that's when you can consider backing down on the dose. There is still likely to be benefit for someone who, for example, is supposed to be on high intensity, but you back down to moderate intensity and they can still tolerate it. Great, use that, keep that going. They will have some benefit there. For the vast majority of patients who have symptoms, they can be managed with this approach. They can continue to take a statin at least some dose where they're likely to have benefit, but first switch statin, maintain intensity, next lower the dose if you need to. And I've said so many things here, and so just giving you a couple links for tools that can help you keep track of all of this. Like I said, ACC is not paying me anything, but I really like the ACC sites for both the calculator as well as the the statin-associated side effects tool. Journal of the American College of Cardiology also has a really nice guideline summary that's like really quick, easy to review and get some of the major takeaways. And we also have a resource that should be in one of your boxes on the screen, which is a common patient questions sort of Q&A, which provides you with another sort of quick, easy to use resource, particularly to guide those questions, those difficult questions with patients and how to have those conversations. Last slide, just a couple of quick pointers on quality improvement strategies for our high-risk groups. So for our people who have clinical ASCVD, what can you do within your centers to improve at least sort of documentation and being sure that these patients are receiving their high-dose statin? What we find with our clinical ASCVD group is that one of the first steps to measuring is just making sure you have accurate documentation happening at your clinics. A lot of these patients are being prescribed a statin already by their cardiologist if they're seeing a cardiologist. And sometimes it's just an issue of clarifying and making sure this patient is actually taking it and then updating the documentation. But if they're truly not taking a statin, that's when you really want to dive into sort of what happened in the past. Chances are somebody attempted to prescribe a statin for this person in the past, and something, went awry along the way. It could have been statin-associated side effects or another issue, so you want to dive into what happened in the past. But one thing you can really lean on with this group of people is that the evidence base here is so sound. There is no question about whether these individuals benefit from statins or whether the benefits outweigh the risks. So, the guidelines are very clear here, and sometimes that's helpful in having conversations with our patients. For the LDL greater than 190 group, some of the approaches can be a little bit different. These patients tend to be on the younger side. They tend to have less frequent visits because they really may not have other chronic issues that are driving them in to see you frequently. So to address these folks, you may need to do some outreach to actually get them into the office to determine where they are and to have that conversation about statin initiation if they're not already taking a statin. And this is another group where you can really sort of leverage the clear-cut evidence in your conversations. You can also sort of lean on this idea that folks who have this very elevated LDL, genetics are very much at play here, and lifestyle, as important as lifestyle is, as helpful as lifestyle is, it is not going to get them, is clearly not going to get them the risk reduction. And medication is really a way of addressing what ultimately is a genetic abnormality in how they metabolize cholesterol. So, sometimes that's useful information to share with your patients. For the primary prevention and diabetes group, this is one group that actually tends to be seeing you on a somewhat regular basis for their diabetes visits. So take advantage of the fact that you're seeing them regularly. Fold statins into other quality improvement initiatives that you're doing in your diabetes population. The tricky part, I know with these patients though, are trying to carve out time on your extremely packed agenda with them where you're dealing with a lot of issues typically. But try to find that time to have that sort of dedicated statin conversation and really take advantage of the fact that you are typically seeing them more frequently. And shared decision making is so important with this group. And so I think I have spoken for long enough here, and thank you all for listening for this long. I hope some of what I was talking about is useful to you all, and I would love to take some questions.
Great, and now we're going to open up the chat line. If you could type your question into the chat, we'll give it a few minutes, and we'll have one of our Health Choice Network staff, Stephanie, read those questions as soon as they come in. So let's give it a minute, and you can formulate your questions. Thanks. Well, we're also going to try one other thing. We're going to unmute everyone's lines for a moment.
Great.
And we'll have people verbally join in if they want. And If it gets too crazy, we're going to mute people back. So Stephanie's going to unmute everyone's line. So just let you know, you're going to be unmuted, and you can verbally ask Dr. Curley any questions also.
Well, what's wrong with her?
So Dr. Curley, this is Dr. Tim Long. One of the things that I learned during the session, among many really, I think is the importance of the blood draw for the liver function test before starting the statin and then ongoing without chronic liver disease. I think I still was practicing that way of uniformly checking the liver enzyme. So any more comments on that? I think that was new to me.
Yeah, we see a lot of people still checking routine liver function tests. Honestly, there isn't a lot of reason to do that in most of our patients. And one thing I didn't mention in the talk, but since we're talking about blood tests for a moment, the guideline finally also talks about how your fasting lipid panels don't need to be fasting. So for sort of screening purposes, you don't necessarily need to do a fasting panel. You can do a non-fasting lipid panel. If you get someone with extremely elevated triglycerides, or you have people who, they have a family history of early ASCVD, they have a family history of familial hypercholesterolemia, those kinds of exceptions, those couple exceptions, you do really want a fasting panel. But for screening purposes, you don't have to have people fasting.
Yeah, I would second that, Dr. Curley. I think that when I go out to health centers, I routinely and commonly see providers asking patients to come back on another day for their fasting lipid panels. So I think that's quite common that happens, and hopefully we can try to dispel that a little bit more.
Absolutely. It's way more practical to get a non-fasting in most situations.
So I don't think we have any questions in the chat, and if there are no verbal questions, we are going to end today's Healthcare Quality Institute for American Heart Month. I want to again thank you, Kate, Dr. Curley, for taking the time out and helping us on this statin therapy is easy 1, 2, 3 ASCVD. Got it, which was wonderful. Appreciate it. And just to let people know, we did record this session, so we will send this out to people who want to have other staff members at your health center listen in on the recording. So I want to thank everyone for the time today. I want to thank Dr. Curley and the American Medical Association for participating with us today, and I hope everybody has a great day. Bye.
Thank you.